Good morning, everyone. You are very welcome to the third and final webinar of 2024 by Healthy Ireland Local Government. The webinar theme today is Enabling Wellbeing, the role of early intervention and prevention. The panel before you today will be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you're using an iPad, you will find this feature located at the top of your screen. Without further ado, I will now hand you over to your host for today, Vinny O'Shea of Healthy Ireland Local Government. Thank you.
Good morning, everyone, and welcome to this Healthy Ireland Local Government online webinar, Enabling Wellbeing, the Role of Early Intervention and Prevention, which is the final of our 3 webinars for 2024 that we are hosting with regard to enabling community wellbeing. My name is Vinny O'Shea and I work in the Healthy Ireland Local Government National Office, which is funded by the Department of Health. Just to give a very quick outline of the National Office, we support the 2 main health and wellbeing initiatives within local government, the Healthy Ireland Cities and Counties programme and the Sláinte Care Healthy Communities programme, where we encourage local government towards improving community health and wellbeing outcomes and addressing health inequalities in some of the most disadvantaged areas in our country. So today's webinar is very appropriate. We also have a European context to our role, working closely with the WHO European Healthy Cities Network. Our national office is kindly hosted by Waterford City and County Council, with reporting arrangements to the Local Government Management Agency and the City and County Managers Association. And I'll be moderating today's webinar. So I'd like to give some context to this, our third Enabling Wellbeing webinar, having already focused on health literacy, approaches within communities, and also enabling wellbeing environments, which was the second of our webinars in October. This morning's theme is exploring the impact of early intervention and prevention in improving wellbeing outcomes within communities, and it provides a nice natural progression and close to the Enabling Wellbeing series for 2024. Early intervention and prevention is a very broad and diverse subject and has so many definitions, contexts, and operates at varying levels to very different degrees. So it's a great platform for disagreement, confusion, and conversation today. But today's event is framed within a local government environment. It explores how prevention and early intervention as approaches can be a strong platform to align, to enhance, and to improve services with and within communities that can result in better long-term health outcomes and, more importantly, prevent poor outcomes in the future. So we'll discuss what early intervention is and what prevention is within a local government context, given the extent that local authorities oversee services and infrastructure that can strongly determine long-term health and wellbeing outcomes, be it housing, be it environment, employment supports, improvements to the public realm, or community infrastructure and services. The webinar will also shine light on practice and experience within the early years environment and in recently created local government structures relevant to creating safer communities. We will also aim to balance this with the reality on the ground inputs that speak to the complexity of health inequalities and hear of the impact of short-term reactionary practice that force communities to face what essentially are avoidable crises over and over again. I'd like to remind all of you that the Enabling Wellbeing series rationale is to explore areas of opportunity and innovation in trying to deliver better public health and wellbeing outcomes for, and most importantly, with our communities. And in this case, to explore if we can do more and if we can do better through intervening early and having a prevention focus to improve the quality of life and wellbeing of communities. It also acts as a strong platform for our team of over 50 people that operate within the local government environment within the Healthy Ireland programmes to start working in a co-producing manner with communities and with other agencies. So we wish to generate good discussion on where are the opportunities to move from reactive responses to more preventative investment approaches, and how can sustained preventative investment be integrated into local approaches within communities. The contributions that make up today's webinar should provide a strong platform for such discussion. And it's very fitting that we have Dr. Austin O'Carroll, a well-known GP and entrepreneur, setting the scene in a general sense on public service and its trajectory based on his experience in the context of neoliberalism. Austin will be followed by Colman Iluk, National SIPSI Coordinator, who will provide context to the work of the Children and Young People Services Committees and the joined-up approach of working with children, young people and their families. This will be followed by an input provided by Dr. Evie Walsh from the Children's Health Ireland, which will speak to the day-to-day reality of complexity experienced in Temple Street and how early intervention and prevention could make a difference. Unfortunately, Dr. Sarah Gibney from the Department of Public Expenditure and Reform cannot be with us this morning and sends her apologies. But we're really fortunate to secure the presence of Grania Burrell, Director of the National Office for Community Safety, who will give us an insight into the new structure of community safety partnerships and the relevance of early intervention and prevention to the new local government structure. And I'd really like to acknowledge Grania for accommodating us at very short notice. The webinar also offers an opportunity to get an understanding of practice and approaches from Scotland with an input from Diarmuid Lawler from the Scottish Futures Trust, who will give a context to Scottish approaches to prevention, preventative budgeting and working within Scottish communities. So I really hope that you enjoyed today's contributions, and by way of housekeeping, I would like to indicate that a copy of today's recording of the webinar, together with speakers' presentations, will be available on our website, www.hilocalgov.ie, after today's event. And finally, I'd like to encourage you to participate in today's webinar by using the Q&A function. If you like or agree with questions that are being asked, you can indicate by your thumbs up, and we will try and weave the most popular questions into the panel discussion, where we have set aside over 30 minutes or so. If you're using social media today, we'd really love to see your insights at #HealthyIrelandLocalGovernment. So without further ado, we will begin our inputs, and our first contributor, Dr. Austin O'Carroll, is on leave in Italy, and I think he'll be quick to tell us and let us know that he's in Italy with his presentation. But he still wanted to contribute to this event, so he sent us an audio message to provide a context for the webinar and challenge our thinking with regard to preventative approaches. Austin is a great example of positive disruption and needs little introduction, so I think we'll be more than interested in hearing his opening remarks. I'd just like to bear in mind that we had asked Austin to give a 10-minute input, and I got an overall input of 22 minutes. So we have condensed it down to just under 10 minutes, but if people would like access to the 22-minute presentation, we can forward that on to people if they so wish. So I'd like maybe now if we could start the Austin O'Carroll input. Thank you.
Buongiorno, and so sorry for not being able to be with you today, but I want to talk to you today about neoliberalism and public service and how I believe neoliberalism ideas have infiltrated public service to its detriment and interfered with its ability to serve communities the way it used to. Before I actually start, I'm going to give you a confession. I'm not an expert in public service. I'm not an expert economist. I'm not an expert in neoliberalism. So apologies if I say anything that offends. It wasn't intended. So, first of all, I'm going to talk about how I believe choosing neoliberalism is choosing poverty. The basic concept of neoliberalism is trying to deregulate society so that the market can operate as freely, and the belief is that the market will achieve a justice for every individual. And in essence, it means weakening the public system and strengthening the private system. However, all the evidence shows that this works to the detriment of people who are in poverty, and it works to absolutely fill the coffers of those who are most wealthy. So how has neoliberalism affected public service? Well, I believe, first of all, it creates this thing called the inefficiency myth. So this idea is that the private sector is efficient and the public sector is inefficient. And so therefore, they say because it's inefficient, it needs to learn from the private sector, and we need to promote more efficiency type practices we need to borrow them from the private sector. So that's led to this concept of public management, where we bring in concepts such as governance and achieving key performance indicators. And this is a form of systematically assessing how subjects and agents of governance are performing and rewarding, punishing them according to neoliberal governance, would thus be creating quasi-markets within a competitive logic akin to that of the markets. So they're trying to create a market within the public service system. So let's say the private public service, I mean, I actually believe it may be true that they do promote some efficiencies in the private sector. I accept that. However, the private sector also increases favoring of simple over complex solutions, selling versus listening. They sell products rather than listening to what people want. Corruption and profit over public services. And I mean, we only have to go back to 2007 to see how I say corruption. I mean corruption, the huge level of corruption with the private sector. And that's because it pushes people to make money. Success is about making money. It's not about serving communities. And I'm going to now talk about what I call the governance myth. I am a fan of governance. I do think it's important to have governance, but I also am quite cynical about governance. I have so many times I get angry when I hear, I believe we have a solution to a particular need amongst, when I was developing health services, I promote a solution and I try and set it up. And people come on and say, what's your governance? And governance for me was often used as a block because you hadn't got this governance. And governance is about responsibility. And I believe in having responsibility, being able to trace where responsibility lies, and governance is about being able to show where responsibility lies so you can improve quality. However, remember 2007, those banks again. Every single one of those banks was supposed to have governance. Every single one of those companies that corrupted, that had widespread corruption in terms of building and selling properties, had supposedly good governance. In the American insurance system in America and the mortgage system, they were supposed to have had good governance. So be careful that you believe good governance implies good practice. I've seen many organizations have really extensive policies and procedures in place, and everyone knows that their services are terrible. So good governance does not imply good services. I'm not saying we shouldn't have good governance, but just be careful that you think governance implies quality of service. It doesn't. Be a bit cynical. Secondly, this is another thing we incorporate from the neoliberal paradigm, is this idea of key performance indicators. And this is the idea of breaking everything down to numbers. In a way, it's that going back to the idea that neoliberalism is scientific. So we can we can count, we can audit, we can compare. So you've done so much of this, so therefore we're able to see you've done more than the other organization. Counting numbers doesn't necessarily work. If you look at the amount of contacts an organization has had with people, that doesn't mean they were quality contacts. Some of the best work I've seen has been with key workers who work with very few people because they've done extensive work with people who are really disadvantaged, cost huge amounts to the system, and they've managed to bring them back in the system and reduce the cost of the system. So, and also you can't reduce social complexity to numbers. So I'm not saying I do audit, I do research, I do measure things. I also look at qualitative data, and I also look and see, is this service working? I talk to people on the ground. What's your experience of the service? So I'm wary of key performance indicators. I'm not saying don't use them, but don't believe that they are everything and anything. A number of organizations I see really rely on key performance indicators, and I see other organizations who I think are doing better work. I also think we got to be really careful of controlling criticism, and this is the thing about community engagement. I've noticed, and we've noticed, I've been head of the drugs task force, and I've been at a number of meetings of drugs task forces, and the prevailing discussion has been about the fact of the reducing influence of drug task forces. And that's because they say people aren't listening to us anymore. Basically, what happens is funding is going towards social inclusion, who is invested in services. So there's less need for the drugs task force. And this is actually, when you read the literature, is part of an international movement to move away from listening to social communities. What we do is we still keep those structures to create an impression that communities are involved, but in fact, we often try and limit, control that voice. So I've seen organizations who have advocated on behalf of their communities defunded, stripped away of funding, because the funders felt it was inappropriate for an organisation they funded to be seemingly criticized. Now, are they advocating for their community? Are they criticizing the public services? I think we in the sector, to be careful, because criticism is not always a positive thing. However, there's definitely a tilt of balance towards defunding organizations who advocate, scaring away organizations, so organizations are staying quieter. And I believe this is actually putting democracy in peril, because you are actually losing that connection with the community. And you know, the communities that we're losing connection are the ones who are disempowered, who don't have any voice. We need people to advocate. We need to keep them having their voice involved. So again, be careful that when you are managing funding, that you don't use funding to control public voice. You engage with public voice. Criticism is a necessary part of it. I accept the community organizations have to manage how they criticize, but just be careful, because it's a neoliberal movement to take away the voice of local communities. Last thing I'm going to finish with the thing is, what sort of community do you want to create? And I sometimes worry that when we're working with communities of deprivation, the types of services we provide are services for poverty. So, for example, as the head of the Drugs Task Force, I was asked to look at the idea of services for preventing drug addiction. And they all looked at these ideas of education on addiction, education on illicit drugs, services to help people come off drugs and to stay away from drugs and support them. And I believe in all them. However, I believe if you have a community you're proud of, that will help you prevent you getting involved in drugs. And how can you make a community you're proud of? A community that has a sense of spirit, a sense of focus. I want to focus on sports projects. Bring in, make sure there's sports facilities, make sure there are sports clubs. In North Inner City Dublin, the biggest building is the actual Croke Park, yet there is no GAA club in the North Inner City. I'd love to see a GAA club. I would love to see more sports facilities. I'd love to see more arts facilities. Yes, there's the Gate, there's the Abbey, but they're the arts facilities for the wealthy people in the South Side. They're not for North Side people. I'd love to see arts facilities for North Side Inner City people. So don't just think about services for poverty. Think about services for community. And think about an environment that you'd be proud of. I think a lot of the work that's gone on in the inner city improving the environment is making a massive difference, because when you walk outside your door, you want to look around and feel proud of the community you're in. So stop making a society to serve the economy, make an economy to serve society that promotes community, equity, education, employment, relationships, participation, environment, future, neighbours, security, and a future for children. That's the most important thing. Thank you very much.
And thank you very much, Dr. Ross. Now, Carol, so be a bit cynical is the message, but I really like the focus and concentration that he's had during all his career in relation to making sure the public voice is really, really heard, and that we look at services and using an asset-based approach. I really think that's important. So I'm sure you'll agree that the scene has been set to think differently, certainly boldly, and to explore what matters to communities, and it gives us plenty of food for thought and some potentially really difficult questions, I think, at the end that Dr. O'Carroll won't be able to answer, so the rest of the panel will be a challenge. So can I now invite Colma Niglu, National Coordinator for the Children and Young People Services Committees, to provide her input. Colma is a huge advocate for interagency working and has been for a very long time, and has spent many years dedicated to enhancing the lives of children, young people and families. So Colma, welcome, and could you please begin your presentation at your convenience.
Great, thanks Vinny. Morning everybody. I hope all the tech is going swimmingly. You let me know if it isn't. So just to say good morning, my name is Colma. As Vinny said, I work at TUSLA Child and Family Agency, and I lead out nationally on Children and Young People Services Committees. So many of you on the call this morning, you'll be familiar with CIPSI, but really what I want to do is really emphasise and set the scene in terms of why we are working in this interagency joined up working fashion. And I suppose emphasising, the tenets and the core principles underpinning what we're doing together through Children and Young People Services Committees. So I want to start with maybe just a really, really quick overview of the policy context in Ireland, because it informs all of us when we're talking about prevention and early intervention. I want to talk a small bit about the actual national model of interagency working that is CIPSI, Children and Young People Services Committees, I suppose showing you how it reflects what the national policy is. The realities of joined up working, so just a little bit around the strengths and challenges. And I suppose really just to emphasise that it's not always easy. but also to share with you some of the, I suppose, the strengths that we have. And I suppose just to emphasize as well around the local knowledge that we have and what the priority needs emerging are. They won't become as any surprise to you, but I suppose it's really just to explain the context for everybody. So this is Young Ireland, and you'll be familiar maybe with this. It's out about a year or whatever, and it actually is sets the scene now for all of us when we're working together around children and young people. CIPSI are concerned with 0 to 24-year-olds, and we're universal. And I think probably everybody on this call in some way or another service touches the lives of children and young people. In terms of Young Ireland, that's the enabling environment that sets the scene for all of us and our work. So I won't go through everything there. We've got interagency working, we've got data research, we've got workforce, parenting support. So there's lots of elements there in terms of what the policy wants to create for us in terms of the circumstances in which we're all operating together in our services. You'll be familiar with the 5 national outcomes for children and young people, and you can see the colour coding in terms of the national strategy and the 5 outcomes and the CIPSI colour coding, and that's all intentional in terms of trying to reinforce for us why are we all working together, what is it are we interested in achieving together for children and young people. And all of us need to be focused on the 5 national outcomes for children and young people. And I have put in a little bit more detail here in terms of you can see active and healthy, because sometimes we kind of streel off this kind of piece and think, yeah, we know all this, but it's good to look under the bonnet again and remind ourselves of some of the detail in terms of what does it mean when we say children and young people will be active and healthy. You know, so it's around making informed decisions. So there's a big health part to it and well-being, about having physical and mental health, that they'd have social and emotional communication skills to achieve their full potential, and that they can successfully navigate. So it's really about looking under the bonnet of all these 5 outcomes that we're talking about, that everyone is alert to child protection issues and knows how to report a concern, but also that children are living in families and in homes that are loving, connected, safe and nurturing. So these are, I suppose, the underpinning reasons that we're coming together through a CIPSI and working together through our services. So it's important, obviously, in terms of economic participation, but also to remember that children's lives are now, they're not economic assets for the future. So they really need, and I think this chimes with everybody in terms of supporting families to have stable housing, affordable, warm and dry, and child and youth-friendly communities. And also the piece around, I suppose the evidence tells us that involving children in decision-making and seeing children as active agents in society now is crucially important. And the evidence tells us that it works in terms of providing better services. So that's really just to set that scene for you in terms of what's the national policy. It mightn't be coming as you see it from your government department or parent department, but it is actually what it joins us all together in terms of what we're trying to achieve for young people, children in early years, and emerging adults or 18 to 24-year-olds as well. So just in terms of CIPSI, we have a national policy by the Department of Children, just to say so to you, that that's our guidance and our policy strategy, and there is a national model there. And I suppose it's not accidental, so it's just to emphasize for you that children are central to our policy, and that's why they're at the core. The 5 outcomes that I talked about, they encapsulate what we're doing, what we're trying to achieve. And we're being purposeful and specific in what we do under CIPSI. And it really is around creating that structured interagency space, having those meetings at a county level. We're structured by local authority county level, even though we're nestled into Tusa Child and Family Agency in terms of our employment and our, I suppose, our governance structure in terms of those types of pieces of work. But I suppose it's important to emphasize that we're not just meeting for the sake of meeting, and people can be critical sometimes of committees and etc. But actually we need to practice collaboration, all of us across our different public sector services and our community and voluntary sector. And that's what CIPSI is supporting people to do, to share best practice, to look at what is the profile in our county, what are the needs of children and young people, how can we design together using evidence responses to the needs in our county. And each county is distinct in terms of what its needs are. And we're intentional in what we do, okay? So it's not accidental, there is a model, and we're intentional in terms of wanting to ensure collaboration and interagency working, identify needs, plan, coordinate, optimize the use of resources that are available in our counties. We really want to promote participation, so seeing children and young people as active agents in the decisions that our services make to deliver services to them. We also want to influence and shape policy. So we have that kind of line of communication to the Department of Children. But the Young Ireland strategy is a whole of government strategy. So that's why I want to emphasise it here in terms of it's for everybody. So this is how we're structured, and most of you who are involved in CIPSI will know this already, so I won't go into too much detail around it. But I suppose we have a main committee and subgroups, and you can see the colours there. They're important because that's our raison d'etre in terms of improving outcomes, okay? But we're utilising existing resources and we attract additional fund streams. But it's important that it's not just about the new funding coming in, it's about using the existing resources from all of our member organisations. And there's about 819 member organisations across statutory, community and voluntary sector. And I suppose the other piece that's really, really important to say around how we're working together is that we have a core set of principles. So when we're working together, we're informed by these principles here, and they're around a long time. I have the legacy toolkit here just to remind people around how to do CIPSI, if you like, and also the blueprint that came in 2015. So really knowing why it is we're working together and how it is we're working together is really, really important in terms of that prevention and early intervention, universal provision space. But at the same time, recognizing that those who need a targeted intervention can also be supported. But really understanding and getting under the bonnet and being informed together with these shared principles and ensuring that we're using evidence to inform what we do. They are why or what we're doing when we meet around a CIPSI. So I talked a little bit, tiny bit about the stats, but just to let you know that that's kind of the scale and the scope, if you like, in terms of our joined up working. And when we talk about CIPSI, we're not just talking about the personnel. Everybody who participates in a committee or a subgroup, etc., you are, and we're working through you, and you're doing the work as well. So just to say, these are the 2023 figures, and these are the members over here. So we're chaired by TUSLA, Child and Family Agency Area Manager, and we have the local authority. So again, won't be new to you, but I suppose it's really important to emphasise that we need to practice that interagency piece in the good times, so that when it hits a critical point, whether that was COVID or whether it was something else or at the Ukraine crisis, that we're ready to mobilise and work together, but understanding how we're doing that together. So that's the piece that comes in around the prevention and early intervention piece, practicing all of the time how to work together and responding to local needs. Donegal needs might be different to Dublin inner city needs, and recognising that, and all of us knowing together, having a shared understanding of our communities. Just in terms of, I wanted to touch a little bit on what the strengths in terms of joined up working are and that, but I suppose the experience in CIPSI is that when you're practicing working together all of the time, and that people are supported and they're committed and they're engaged, and there's a kind of a common agenda. Everybody has their own business plan and structures and policies that they have to deliver on, but children and young people are our focus, and we deliver projects successfully. We're focused always on the outcome. What outcome? Why are we doing this? What does the evidence tell us about whether it works or not? And we're focused on delivering then for that purpose. That's not to say everything is perfect in a rosy, and I'll talk a little bit about the challenges, but in terms of what is working, there is really excellent engagement from member agencies and organisations. They are delivering on the ground. It's not just the talking shop, and the collaborative work obviously supports everybody. In terms of the challenges, just because I'm conscious of moving through, just the workload for everybody is getting harder and it's more stretched. The needs of the community are getting more complex, or that's how we describe it. Maybe we're just getting better at seeing what the different needs are, you know, but like it is becoming more complex out there in terms of responding to diversity and to need. And we need to recognise that in terms of when we're engaging with each other. And then funding related challenges. Obviously, everybody would like to have more than an annual budget, annualised funding, different funding streams for different pieces of work with different labels on them, etc. So they are some of the real challenges in terms of when we're working together. So we really need to unify around the population piece. And for us, that's CIPSI, and that for you, that's CIPSI in terms of the prevention, early intervention space and achieving positive outcomes for children. Just in terms of us, in terms of our own governance, and Austin mentioned governance, we do collect data, we do report in. I don't have enough time to go through everything, but I suppose it may be no surprise to people to know that Children and Young People Services committees consistently for 5 years have reported that the mental health and wellbeing of children and young people is a priority need. So I suppose we are an excellent source of intelligence, and we're using some of the funding that we get, whether that's Healthy Ireland funding or whether it's international protection support funding or parenting awareness funding. We are using that to put in interventions around promoting health and well-being. We're not providing psychiatric services, but we are trying to promote at a population level mental health and well-being. And for 2023, these were the priorities, and actually they chime quite well with Young Ireland spotlights in terms of some of their priorities around mental health and disability. New communities are in there, knowing how to, I suppose, support the integration of people from different countries coming in and being successful in trying to support people in that way in terms of living in difficult circumstances. I'm going to leave you with this slide, which is to encourage people to think about, if we had a fully functioning child and youth friendly county, what would it look like? Well, in CIPSI world, it means that we would be consulting with children and young people. We would be treating young people and young people with respect and valuing them for who they are now, not who they'll become. We would have the key stakeholders around the table. We'd be using data to make decisions. That's people's expertise, your expertise, research, data on outcomes. Families as the central unit, and a good line of communication, top down, bottom up. And that we would really be looking that every community would have really strong parental support and quality pre-birth services, a good, well-structured and well-resourced community-based resources, urban and rural equity, and that those who need more get more, but at the same time recognising that we're working to support a population of children and young people. So I'm going to end there and just to say thank you very much for listening, and I encourage people to join with us in terms of our interagency work. We all have our own agendas, but we are a space to work together for children and young people, and we're practicing that collaboration and supporting you to do that and building that culture. We know what's happening, and we ask you to join with us and work through us. So thanks very much.
Thank you very much, Colma, and many thanks for your excellent contribution. I really like your emphasis on looking under the bonnet and making sure we relook at it. It's so relevant, I think, to the work of all the other elements within local government, particularly in regard to early intervention and prevention. And I think your final slide, I think that could refer to any piece of activity of what would a fully functioning city or county look like, whether it be for Sláintecare Healthy Communities, a healthy city or county, integration, climate action. It's all those things in relation to. So I think it's a really, really good focus for us, and I think it's going to give rise to a lot of activity on the Q&A. So thank you. Moving swiftly on with, I suppose, a nice natural progression from Colma's input, we are delighted to invite Dr. Evie Walsh of Children's Health Ireland, who operates from Temple Street Hospital, and is going to provide detail of our work in relation to children's health and the everyday reality of complexity experienced in our work, and how more preventative approaches could lead to better outcomes. So, Evie, thank you very much for agreeing to participate. You can begin your input whenever you're ready, please.
Thank you so much. I'm delighted to be asked to speak today, and I suppose I always have a lot to say, so feel free to jump in if I'm going over time, Vinny. Thank you. So my name is Dr. Evie Walsh. I set up and run the Lynn Clinic in CHI at Temple Street, which is a community outreach clinic for children experiencing significant social exclusion. We look after children from the northeast inner city, but to be honest, I play fast and loose with my catchment area. So I look after children all over the Dublin area and sometimes into Meath and Kildare as well, with the kind of unique factor that they are all experiencing significant social inclusion and social deprivation. And I suppose I am a hospital practitioner. I do admit children. A lot of the work of this clinic is done as an outpatient. And I suppose when you talk about primary preventative health, what I do is really secondary and tertiary level pediatrics. But what I hope to show you today is that it's not all, as I'm sure you're all aware, but it's not all in silo. These problems start out in the community, but by engaging children early on with sometimes what is hospital level investigations and support, we can really mitigate the escalation of what can be sometimes very common pediatric conditions. But when you add in the layers of social exclusion, poor health literacy, poverty and homelessness, you really are looking at a really complex system to navigate for both the children, the caregiver and the health and social care professionals involved with them. And I suppose we all know that reducing health inequities and improving health for all requires cross-sectoral work, as well as a strong local and regional engagement. And integrated care is such an underpinning of sláinte care. And I find sometimes you can be on a lot of discussions as to how to do integrated care. And I would say just start doing it. Get out there in the community, which is what our clinic has done, and get to know the real key stakeholders of health. People like the public health nurses, who for me are the warriors of healthcare in the northeast inner city Dublin. They're the ones on the ground who've built up the really long-lasting relationships with families who we use to navigate engaging them then with the hospital care. So sorry now, I'm just trying to move my slides. So this was quite a depressing 90-second brain dump that I did on my kitchen table of all of the different social determinants of health that can impact a child that I see in clinic. And we all know homelessness is very topical. It's a huge crisis. I really want to highlight that our homeless figures are registered homeless with the various city and county councils. It does not include the number of children living within the International Protection Accommodation Services, nor does it include the hidden homeless, where people might be registered to an address. I have families living with grandparents, with friends, sleeping in cars. So our homeless figures really do unfortunately underrepresent what is already a crisis. We look at things, forced migration is of course something that everyone is aware of, and we're looking at again exponential increases in the figures of people coming into Ireland seeking international protection. And we were familiar with the government white paper that was released that essentially did admit that direct provision was not fit for purpose, and yet it was a system already not fit for purpose before it had the burden of essentially collapse with the number of people coming in. I have to say I work very closely with people in IPAS, and like everything, I work in health. The people on the front line on the ground every day are doing above and beyond what they can do to support children and families. But I'm looking at women trying to wean infants in repurposed industrial facilities where there might be 2 bathrooms and 2 microwaves for 500 people. We are looking at women post-cesarean section, breastfeeding young babies living in the same setup. We're looking at children with significant neurodiversity across both registered homeless and IPAS, living in single hotel rooms with 4 siblings and a single parent, who have self-injurious behaviour, who don't sleep, who have food avoidant restrictive disorders, who are not thriving. The list goes on as to how problems faced by all parents are hugely compounded by homelessness. As well, I talk about the far right as well. I have children and families in the northeast inner city who still won't go out and bring their children out because they don't look and they aren't ethnically Caucasian, white Irish, and they are the subject of sometimes very vicious verbal and occasionally physical abuse, which I would not subject my own children to. And because of that, we're also seeing large figures of complex obesity in homelessness, especially in the northeast inner city, where parents and caregivers just simply can't bring their children outside because they're afraid, which is just heartbreaking. What we do in our clinic as well, we talk a lot about caregiver or parental health and well-being, because a huge amount of the children and families we see, in particular the mother, is either a previous victim or a current victim of domestic, sexual or gender-based violence. And that in itself has a huge impact on their capacity to parent. If you look at Maslow's hierarchy of needs, we often see parents who are still in mental health crises themselves, experiencing active PTSD. And truly, I think they're doing an amazing job just keeping their children warm, fed and clothed. But we might look that their child is on screens, 8 hours a day, that they're eating refined processed carbohydrates, they're buying fast food because their child won't eat the food that they're given in the hotel. And I think these parents often come to places expecting to be judged, and often that can be a barrier to them engaging, when really I have nothing but admiration for what they're managing to do in the most incredibly constrained circumstances. We look at things like the food pyramid, like healthy diet, and again, sometimes in hubs or in B&Bs, people are given an allocated kitchen time, but they can't bring children into the kitchen. And if you're a single parent of 5 children, the youngest of whom is 13 months, you cannot bring your children into the kitchen, but if you leave them unattended, you're reported to management and to the Child and Family Agency. It's a mandated system, so you can appreciate why they can't cook the food that they want for their children. So while all of these are international headlines, they're national headlines, they're global, national, local issues, when you see the day-to-day impact into this care, you see how much of a change can be addressed not by a hospital system, but by changes in public policy and how we have insight into the day-to-day lives of these families. I look at historical trauma as well. You see it in the Northeast inner city, the generational cycle of neglect and deprivation. We have a huge amount of children. I think that Dublin inner city is supported by grandparents. I see so many children who are in the care of grandparents with parental incarceration, parental death, parents actively working as sex workers with substance misuse issues and mental health difficulties. And it is a real, true generational cycle of deprivation and neglect. As well, I look after about 1 in 4 of the children I look after for the Roma community. And again, if you look at their historic trauma in terms of segregation, discrimination, that's still active and ongoing, both in Ireland, but systemically in parts of Eastern Europe. And also the fact that they were victims of the Holocaust and their children were preferentially selected for medical experimentation. It is no wonder they might be reluctant to engage with hospitals, with doctors, with general anaesthesia and procedures. So having a knowledge of all of these different factors that are in the news that we see, but bringing them into the day-to-day life of a family can really help to understand. These are just some of the key concepts, and I'll fly through them. We all know social exclusion is when children, families, people are living outside the normal constructs of society due to, as I said, local, national and global policy. And we know that 1 in 3 premature deaths worldwide are directly attributable to social deprivation. I've talked a little bit about intergenerational disadvantage. Trauma-informed care is a wonderful concept that we've obtained some training in, and we're trying to progress that, but it's really not asking, why are you here today? It's what brought you here today. It's understanding specifically for us, the caregiver's attitude. Sometimes you come across difficult parents who can be really challenging in a clinical setting, or who may fail to engage altogether. And really you're looking at what has happened then, that their instinct, their threshold of tolerance, they become, very fight or flight, they become aggressive, and it's because of what's happened to them in the past. And it's about understanding their behavior through that lens to continue, as appropriate, to provide support and interventions to them and their child. We've discussed the social determinants of health, all these policies that as an individual practitioner, I feel I've no control over, but understanding that they are there and how they impact children. Things like our medical card. I look after a huge amount of children with autism spectrum disorder, and melatonin is not available on the medical card. And these children are living in hotels and B&Bs where the child with autism is awake all night screaming, banging their head against a wall. They're getting complaints made about them. It's keeping all the other children awake who then can't engage with school. And it's something as simple as the fact that the one medication that they need, they cannot get through an affordable prescription system. Our drugs payment scheme is €80 a month. It does not, that's unachievable for many of our families. Intersectional marginalisation, you can't have an umbrella approach, because the needs of a recently arrived Palestinian child who's come into the direct provision system, who's watched his mother die in a bomb, is very different to the needs of a homeless Roma child or a homeless Irish child who has that kind of generational cycle of trauma and neglect in their history. So while we do offer a kind of planned pathway of care, we do really try and tailor bespoke approaches depending on the population and the child and family need. Social prescribing, the medicine I always say is the really easy bit. I can identify eczema, I can identify a child with epilepsy, I can identify a child with cerebral palsy. It's all the other supports that are needed to make a plan. It's at hospital, we live sometimes in an ivory tower. I can write a beautiful letter with a beautiful plan and then watch it all fall apart if we haven't put the other necessary structures in place. Something as simple as a child who has a genetic myopathy, which means a muscle problem. Sorry, that's the election canvassers at the door, I'd say. I'll just ignore it. But children who have, he has a myopathy and he can't walk for more than 10 meters, but his mum had to engage with disability services, with hospital investigation. She was pregnant when we met him. She then had a little baby, and we got her a double buggy so that she was able to navigate hospital and community appointments on the public transport system, which sometimes took 2 buses and a Lewis. And imagine trying to carry your 2 children. So a double buggy was actually the biggest thing to change his outcome and engagement with services. We all know about adverse childhood experiences. The children attending our clinic have at least 4 or 5 of them each, and we know that leads to shorter life expectancy, higher health risk behaviours, higher risk of non-communicable and communicable diseases. The allostatic load is a concept which combines physical and psychological stress to advance aging, advance inflammation, and increase frailty. And I see it even in the younger children attending us today. And I've mentioned integrated care, and down at the bottom here, and I have a map a little bit later on about, we don't just work with the hospital, we work with various health agencies, non-health agencies, government departments, non-governmental organisations, and it really does truly take a village to help to support these families. I've kind of gone through this, so I'll fly through, just keeping an eye on the time. So how do we do this? Well, we moved our clinic out of the hospital. Sitting in the hospital doesn't help. We went to a local primary care centre in Summerhill, where the children and families already know how to get to it. If anyone's ever visited Temple Street as either staff or family, the place is like Hogwarts. It's impossible to navigate. And we've had people make it as far as the front door and then get lost and not show up to appointments. So we've brought our clinic out of the hospital, which has really enabled us to get to know our local community. If I waited for a GP referral on every child, I'd have an empty clinic, because over 50 or 60% of the kids I see don't have GPs. So we've really gotten to know, as I said, Focus Ireland care workers, people from Pavy Point, Roma peer support workers, IPAS, support staff, HSE homeless health links. We take referrals from all across the community, and what we do is then we provide that piece of primary care while we support engagement with that infrastructure. And often we direct families to the safety net practice. We're very lucky in Dublin that safety net will provide primary care to people while they wait a GP and a medical card, but we take direct referrals. We really do link and engage. Proactive liaison and support. The biggest, people ask me, how do we do it? We've really good attendance rates. WhatsApp. We don't just send a generic reminder appointment. We don't just send a letter. Most people's, but a lot of phone numbers have changed 3 or 4 times, even if we're seeing a child within 6 weeks of a referral. So we WhatsApp, we use the translate function, and we directly confirm appointments. If we don't get direct confirmation, we link with any caseworkers, we link with TUSLA if they're under the remit of TUSLA, and we find the children and we bring them in. And as I said, it doesn't just stop in clinic. After clinic, we support with prescribing. We ring the pharmacy if there's difficulty. We give our team's phone number on the prescription for those that don't have English. And we follow on with the Children's Disability Network team. We also now work with TUSLA, and we're seeing the unaccompanied minor children under 16, because as well as offering communicable disease screening, we do a holistic healthcare assessment. We've already diagnosed children with HIV, older children, chronic hepatitis B, and we've identified a number of young women who've been the victims of female genital mutilation earlier in childhood, and not only have the physical issues of this, but that really profound unaddressed. So this is our kind of operational pathway. I've discussed a lot of this already, but as I said, we take referrals. I'm not sure if my clinical director knows this, and I don't flag it with them, but as I said, we take referrals from all health and non-health stakeholders looking after these children and families. We've a really robust registration process, confirming phone numbers, confirming addresses, really informed triage. Something might strike you as quite straightforward, a child with asthma who's been in hospital twice, but if they haven't managed to procure inhalers, if they haven't understood how to take them properly because of language and health literacy barriers, asthma is a potentially life-threatening disorder. So knowing that, and that they're living in homelessness, that they don't have a GP, what might be triaged as routine in another clinic, I will triage that more rapidly, because coming into the winter season, I also we're trying to scale it up, but obviously staffing constraints, but we're offering opportunistic MMR and seasonal influenza vaccine for the children coming to our clinic, because even in vaccine hesitant populations, like people from Eastern Europe and the Roma population, we actually find a lot of them buy into it there and then. So if you have the vaccination there and then, you can give it, whereas those we kind of convince and talk around giving the vaccinations. If we send them out, they rarely, if ever, actually subsequently attend the GP or primary care for vaccination. And as I said, some children, if a child has really significant needs, we have 2 children who have physical disabilities and a mum who's a polio survivor, we will support them with taxi transport to the hospital. They would be 3 combined forms of public transport getting into us, and these children really need hospital care, because if we don't, they will end up admitted with complexities of their medical condition, which to my mind will cost a lot more. As I said, we try and be trauma informed, culturally competent as well, and do a lot of opportunistic health promotion. We have a lovely partnership with the HSE primary care dentists who see children on site who attend our clinic. And unfortunately, it's because it's so high yield for severe dental caries needing extraction. They not only screen the children, but also any siblings. Equally with vaccinations, we offer them to all children coming. After the clinic, we continue our support, as I've referenced. And the biggest thing, I suppose, especially in homelessness, is the transience. So if children move, we find them and we refer on to local services, highlighting their social exclusion and their high risk of disengagement. We will repeat investigations in the absence of a GP. If we treat a child for iron deficiency anemia, we will bring them back and repeat the bloods, rather than kindly asking a GP who doesn't exist to perform them. Very low threshold for directly observed therapy, in particular iron infusions and high dose vitamin D. We see a huge amount of severe micronutrient deficiency. And again, coordination of engagement with radiology for MRI scans under GA, which are a huge and costly intervention. But if a child needs them and then doesn't attend, it's a waste for all who need the service, not just our own children. Sorry, just keeping an eye on how I'm doing for time. This is just pathology. 1 in 3 children I see are coming for developmental issues. And when you try and tease that out in light of their deprivation and trauma, it's very hard to know how much is organic versus how much is purely environmental, which is actually really sad when you think about it, that a lot of children with really significant developmental challenges, it's all bred because of their environment and exclusion. These are just some statistics. Half the children I see are under the age of 5 and already experiencing health problems as a result of their poverty and social exclusion. Over half have no medical card or GP. Year on year, 1 in 4 are members of the Roma community. 65% require an interpreter. The figure for emergency accommodations is out of date. It's actually 86% now. 1 in between, again, our attendances reflect news. So we're seeing more and more coming from the international protection and refugee population. Just over half have up-to-date vaccinations, which in the context of, say, a measles outbreak is shocking when you're looking at herd immunity needing to be up above 90%, and all of these children living in overcrowded accommodation. 5.5% are under the care of TUSLA, either as unaccompanied minors or because of child protection concerns. And as I said, a very high prevalence of micronutrient deficiencies. I'm just going to check how I'm doing for time. I have a little bit of time. So I'll just give one of these examples. I've mentioned anemia. So my colleague, a child came into the Temple Street A&E with a fingertip injury and was found to be anemic. And they referred her to my colleague, a consultant hematologist, who's excellent, but she's the only one working in Temple Street and her service is very oversubscribed. And she looked at the blood tests and looked at the fact that the child was living in a hotel and rang me and said, Aoibhinn, I think this child is probably nutritional anemia and they're homeless. I think they'd be better fit with you. I said, absolutely. So we saw the child and absolutely she had iron deficiency anemia. She also had skin infestations all across her scalp and her groin. She had really bad untreated eczema. She had severe dental caries. Her teeth were all rotted to the stubs. And she was significantly underweight. It also transpired in the consultation that she was the product of significant gender-based violence. She was a conception via rape, and her mum had never been tested for communicable diseases, including HIV and syphilis, and neither had the child. So what started out as nutritional anemia is a very common pediatric referral. But when you start to peel back and ask the right questions, we figured out a huge amount more. And we're then better able to support this child. She couldn't eat properly because of the pain of her teeth. So we gave her an iron infusion. She got the rotted teeth causing pain extracted under general anaesthetic. We performed her communicable disease testing, which was thankfully negative. We treated she had a fungal infection superimposing eczema and scabies. So we treated all of that and we discharged her recently. She's absolutely fabulous. We also started her on oral nutritional supplementation while we waited for the teeth to come out. We linked her mum in with the Dublin Rape Crisis Centre, and she also got communicable disease testing, which was thankfully negative. So if you look at something really basic, nutritional anemia, and just keep focused on that, you miss all of the other facets, which would lead to a much worse health outcome. So while we haven't treated the homelessness or those environmental issues, we were able to take them into account and understand and diagnose a lot more that we could manage with this child. This is a map of our integrated care. So as you can see, we put the service user in the middle, but the hospital is only one little piece of that screen. Huge amount of collaboration and work with non-governmental organisations and community advocacy like Focus Ireland, Paddy Point. We talk to the HSE all the time, that what was the CHO, now the health regions, acute operations, HSE social inclusion, public health, dentistry, disability and primary care. We have all these people on speed dial sometimes. And it's the one thing I'll say is it's much harder to say no to somebody or to kind of put a pin in something if it's in an email. The biggest thing I think to provide integrated care is picking up the phone, meeting people directly. We link with the Department of Children around IPAS and TUSLA. We've very good links with the Separated Children's Unit for the unaccompanied minors we're screening. We often advocate for the majority of the children I see are in homelessness, but with specific, really significant medical conditions, people requiring dialysis, wheelchairs. We do have links with city councils, work with the Department of Education. I don't have the exact numbers to hand, but many of the children I see are not in school placements and they may or may not have additional needs. So we work with the special educational needs officers and educational welfare support officers in IPAS, and we're trying to, I suppose, spread the word with our own professional colleagues. We link with the National Clinical Advisor for Children and Young People through the HSC, the RCPI, the Royal College of Physicians, which is the physicians' educational body, and we're trying to establish formal academic partnerships with the big medical education universities, UCD, Trinity, DCU, and RCSI. So these are just some testimonials from not the families yet. We're working on semi-structured interviews, but from the stakeholders who refer children to our clinic. And I think the one here that really always speaks to me is, without this service, I have no doubt that the children who've been helped by the team would have slipped through the cracks, leading to much lost potential later in life. And that's what we're looking at. We're looking at the chance to intervene early and really set the, if you can't address the homelessness, at least address the health needs. Treating iron deficiency and vitamin D deficiency in a child who's fatigued and not engaging in school could be the difference between them actually attending and having meaningful education. So I say the medicine is the easy part, but it's recognizing all of these other pieces have to fall into place. And lessons learned, future planning. I suppose our team is only temporarily funded. I'm just putting that out there for it's a huge part of what we do in a busy job, is trying to establish recurrent and permanent funding, and we're at the risk of staff attrition. We've very skilled staff now, but without a permanent contract, it's very difficult to retain, as everyone knows. Our clinic mirrors the global challenges. It's in a local context, and we are not going to see the housing crisis or forced migration or the cost of living improve anytime in the near future. So services like this, with that partnership with all of the people working to keep our own communities healthy, is essential. It is integrated care, and the very really fundamental meaning of integrated care, it's hospital and community coordination. We're establishing effective pathways of care. I'm working with a group of other interested paediatric consultants to formalise this, because ultimately we will need and we want a structured model of care. We've clinically applicable findings. We have research submitted for publication, including the fact that our attendance rates are over 90% in these populations. Unfortunately, we don't have comparative data because our hospitals are very poor at recording ethnic identifiers and nationalities, as well as addresses. People might not know that 41 Gardner Street is actually the townhouse B&B. So it's very difficult to have data to compare it to. We operate on a needs-based response. We were there when the Ukrainian conflict started in 2022. We're now seeing children arriving from Palestine, Jordan, and Egypt. We really want to engage with more service user input, but as I said, that takes time and resources, but we really do feel it's fundamental to have a co-designed service. And we have identified subgroups such as nutrition in homelessness and migrant health that we're working on to create hospital clinical guidelines that I hope will feed into updating national guidelines. Ultimately, we want a full service with transferable templates of care that continue the trauma-informed care model, and to have either specific inclusion health services or an inclusion health champion or ethos amongst acute hospital services. Thank you so much, and I'll of course take questions at the end. Appreciate it.
Thank you so much, Evie, and I know you really appreciate your participation because you have a hectic workload. Thank you for the reality therapy. Thank you for, I suppose the one thing I'm going to say to you is, and I'm going to speak on behalf of all the attendees, how can we help? Because this is really, I think that there's a number of questions coming in. Really appreciate what Lynn Clinics are doing. The high rates you have in relation to attendance is a model that's there that could be used in other healthcare areas. I think we have questions in relation to that. I'd love to hear your views on what local government efforts could make most impact over the longer term for you and your work, and perhaps we might look at that later. But yeah, if there's any way we can help, and I really think there's an opportunity for the Sláintecare Healthy Communities programme with the local government context to really be able to support you, and likewise maybe you might be able to support them, because we need to work together in that space. So really appreciate it. Thank you. So moving on to, I now want to introduce you to Gráinne Burrell, the Director at the National Office for Community Safety, which is a recent structure to oversee and support the rollout of local community safety partnerships. So as I said earlier, I was delighted when Grania agreed to participate at such short notice. I really look forward to hearing the early intervention and preventative contexts, Grania's input. So if you'd like to give us your insights and its relevance for overall local government activity, please, Grania, whenever you're ready.
Sorry, I'm just trying to share my screen here, Vinny. Is that up there?
It is, Grania.
Great, thanks a million. So good morning, everybody, and thanks so much to Vinny for giving me the opportunity to speak to you today. As Vinny has said, I am the relatively recently appointed Director for the National Office for Community Safety, which is a structure that's being established at the moment. I'm just going to give you the whole kind of new community safety approach, which emphasises proactive, preventative, collaborative interventions to achieve better outcomes for communities. It's really, we're embarking on that exercise at the moment, so we're at the start of our journey, really. So I'm going to introduce you a bit to the local community safety partnership structure that's being implemented, give you a quick overview of the national structures that will support the local partnerships and the implementation of this new approach, and then kind of look at where we're at and what our next steps may be. So I suppose just to start with, what's the background to this new approach, and I'll go into that a little bit more in detail in a moment. And really, the report of the Commission of Future Policing in Ireland was really the genesis of this approach, and it identified the need to go beyond traditional policing when dealing with issues related to community safety. And following the publication of that report, the Department of Justice then developed a community safety policy, which gives a general general overview of what community safety is. And I suppose it places particular emphasis on the role of local community safety partnerships. Recently, this year, the Policing Security and Community Safety Act was signed into law by President Higgins. That actually legislates for the implementation of many of the Commission's recommendations, and Part 3 of that Act places a statutory obligation on government departments, local authorities and public sector bodies to have regard to harm prevention in their activities and to cooperate with each other to deliver safer communities. This Act also legislates for the establishment of local community safety partnerships, the National Office for Community Safety and the national governance structure that I'm going to speak about in a moment. So what is community safety? Simply at the heart of it, it's the principle that every community has the right to feel safe, to be safe and to feel safe in order to thrive and to flourish. The Commission report back in 2018 identified that Gardaí, they're increasingly finding themselves dealing with the most vulnerable members of society, and significant amount of policing time is actually spent on harm prevention rather than crime-related issues. But I suppose many of us will recognise that the causes of crime and criminality, they're often complex and they're often interconnected economic and social conditions, ultimately the same social determinants that underpin individual and community well-being. So this new approach to community safety repositions community safety as the provision of social services with a proactive and ongoing input from a range of public and community services. And thinking about what Dr. O'Carroll said earlier about the disempowerment of community, I haven't moved on screen, sincere apologies. Thinking about what Dr. O'Carroll said earlier, like about communities being disempowered, this is an approach which actually seeks to empower communities to have a stronger role to play in the identification of safety issues within their own communities, and along with the prioritisation and delivery of actions in response to those issues. So ultimately, it's about moving beyond reactive responses to emergency crisis situations towards prevention and early intervention through a collaborative, shared approach to problem solving and creation of safe communities. So the local community safety partnerships ultimately are like the front line of the delivery of this new approach. It's essentially, if we look at community safety, it's underpinned by a collaborative, partnership-based problem-solving approach. And the role of the local community safety partnership is to foster that sustained community involvement in identifying their needs and in co-designing solutions, and sustained commitment from services to work together to address those needs. Looking at the objectives that are there on the screen in relation to local community safety partnerships, in terms of prioritising issues, identify the community as safety concerns. In this structure, the community will be engaged with and represented on local community safety partnerships, and they will also contribute to the development of local community safety plans. In terms of improving multi-agency collaboration, all of the relevant service providers are represented on the community safety partnership, and I'll in a moment speak about that structure and who's on the partnership. And they're all there to work collaboratively on solutions to those issues. And in terms of increasing community confidence in service providers, which we all know is one of the challenges, and Avian just mentioned there earlier about communities with intergenerational trauma, and why would they not? Why would we expect them to engage with services? So in terms of service providers, they're going to be accountable through these structures to the community, because there will be agreed actions identified in the local community safety plan that they will have responsibility for. And in addition, the idea is the community will be better informed about and better empowered to participate in community safety activities in their area. And I suppose that speaks to in the Commission report, it was very much around community safety is not just the role of the police, it's all of our obligation. We all have an obligation to community safety. So looking at the composition of the local community safety partnerships, it's intended that residents will be a key representation on the structure. There will be community representation, whether that's youth, new communities and the voluntary sector. And I was struck earlier in terms of SIPSEs, that whole thing about the youth voice is so important to have in terms of service design and delivery. Local elected representatives will also be on the partnership, as will business and education representatives and relevant public services in the area. So that includes the HSE, TUSLA, local authority, and of course, An Garda Síochána. There is actually a maximum, it's anticipated there will be a maximum of 30 members, 20 of whom will be mandated. There'll be the people I've just mentioned there, but there's a lot of scope within the up to 10 additional seats for local authorities within their own area, for the chair and the partnership to identify the needs for their area and who would be best represented to represent those needs. In anticipation of the rollout of partnerships nationally, the Department of Justice have actually been running pilots in Dublin North Inner City, Waterford and Longford since 2021. And each of those pilots developed and launched their own bespoke community plans, which they are in the process of implementing. The plan set out agreed actions to be undertaken by the members of the partnership to enhance community safety in that area. There are differences within the plans which reflect the responsiveness to their local area. However, there are also thematic similarities. And I suppose all 3 local community safety plans are available online, and it's worth having a look at them, just particularly as local community safety partnerships are being rolled out nationally, just to get a sense of what the issues that they have identified in their areas. All 3 of the pilots were also subject to a robust independent evaluation conducted by the University of Limerick in conjunction with the Centre for Effective Services, and this has now been published on the department's website. And in terms of the key finding of the evaluation, the majority of partnership members perceived their partnership as having considerable benefits and added value, and it really is about that added value piece. Through building relationships locally, capturing a more authentic and representative community voice, and planning and delivering holistic, community-driven, solution-focused responses to local community safety issues. And the overall conclusion of the evaluation was that the local community safety partnership model validates the approach to community safety in terms of being a whole of government responsibility, with the community voice and involvement as the core feature. There are a couple of key personnel in terms of the community safety partnership structures, and the evaluation of all 3 pilots also tells us the role of the chair will be central to the success and the momentum behind the partnership. Their role is to lead the work of the community safety partnership, ensuring its effectiveness, to set expectations regarding culture, values and behaviours for the partnership, and to be instrumental in ensuring all voices are heard and that the partnership stays solution focused. And that's really, again, about making sure that the community voice is at the table and is heard as well. They really have a key role to play in finding consensus among the partnership members so that the tailored local community safety plan can be developed. And I suppose it's worth noting here that local community safety plans must have regard to other local area-based plans, such as the local economic community plan in particular, and also other plans such as SIPSE plans. Their role is also to drive forward the implementation of the community safety plan across the community, so it delivers tangible benefits for the community itself. So it's actually a high-level volunteer role, which requires dedication and time. It's a very specific person that will fit that role, and they'll serve their term of 3 years. The other key role within the partnership structure is the coordinator. And again, I'm struck by what Avian was just saying there about the challenge of recurrent funding. So the Department of Justice has actually, following the evaluation, we found that the recruitment and retention of good people, in particular the coordinator, is it's a significant success determinant. So the department are actually resourcing the 2 staff positions within local community safety partnerships as permanent posts, totally recognising that need for that continuity. We provided a role description there, which was informed by learning from the pilots, and because the coordinator's role is really about working collaboratively alongside a wide range of stakeholders, including colleagues within local authority structures such as Healthy Ireland coordinators, Sláinte care coordinators, local sports partnership coordinators. I'm struck again by what Dr. Carol was saying earlier about arts and sports and ways of building up communities to make communities safer. They'll have to work with housing teams such as tenancy liaison officers, operation teams, local area integration teams. They also have to develop close working relationships with An Garda Síochána and other statutory bodies such as TUSLA and the HSE, structures such as SIPCs, regional drug and alcohol task forces, and the broader community. So really their role is very much in essence about building relationships. And again, Aoibhinn spoke there a moment ago about picking up the phone being one of the most useful tools in terms of integrated care. That's the case here as well, being able to be able to link in with people and get their support in terms of the community safety project. The infrastructure, so local community safety partnerships, they'll have strong support from national level. So there's a designated cabinet committee who'll provide high level political oversight and accountability to government. Then there is at senior official level, and there will be National Community Safety Steering Group to provide senior leadership and direction for the implementation and fostering interagency cooperation. They'll have particular focus on the national strategy. So there will be a national safety strategy published, which will provide overarching policy framework and programme of actions underpinning the whole of government approach to community safety. And then obviously there will also be a national office, which is being established at the moment. Apologies going on too far. So that national office actually comes into being when the Policing, Security and Community Safety Act is commenced, which we are all working towards, hopefully the 16th of December. That's the current date for commencement. The functions of this office are actually stated in legislation, and the office will actually have national responsibility for the delivery of the National Community Safety Strategy objectives as directed by the National Steering Group. So the National Office will have a role in terms of supporting the steering group as well and in delivery of the national strategy. But actually a key function of the National Office is to provide training, guidance and other supports to local community safety partnerships, including assisting them in formulating local community safety plans. And we're doing as a team a lot of scoping work at the moment, such as engaging with colleagues across other departments and jurisdictions to identify best practice in terms of data collection, metrics, and providing an evidence base for the work of local community safety partnerships. So we've looked at things like the Place Standards tool from Scotland, and thank you, Vinny, for pointing us in that direction. We've also had conversations with the Mayor of London's Violence Reduction Unit, because they're just recently developed an outcomes framework there that might be of use. We're engaging with other departments, such as the Department of An Taoiseach, the Programme Board, in building stronger, more integrated responses to local area challenges. So we're kind of at the outset, at the beginning of our process there. We also have a role in terms of promoting public awareness of issues affecting community safety, and I suppose that's around consistent messaging about what community safety is, why we're all trying to work together, what are the outcomes we're trying to achieve, and I struck earlier on about the way that the SIPC colour, look and feel and everything maps back to Young Ireland policy, and we're looking at it similarly in terms of developing branding and communication guidelines for the local community safety partnerships. So where we're at and next steps, conscious of time. So we're keep going with the establishment of the National Office of Community Safety. There's a new team being put in place there, and we're getting our own office space. The drafting of the local authorities are continuing to recruit and select their own personnel with support from ourselves. In terms of the drafting of regulations, final preparations are underway in terms of the commencement of the Act, which includes finalising a suite of secondary legislation to support commencement, which will cover, in addition, regulations governing the local community safety partnerships. And I suppose the evaluation of the pilots, they've actually identified learning and enablers in terms of supporting successful implementation. So the National Office are in the process of developing a comprehensive guidance document for local community safety partnerships, which is informed by this learning and will also reflect the regulations as per secondary legislation. I suppose in terms of the local community safety partnerships that's been rolled out nationally, the learning from the evaluation is that the pace of setup will vary, as will the challenges that will arise across all locations and local authority areas during the rollout. So we recognise that, and I will be providing support to local authorities through this rollout phase. And then finally, the National Community Safety Strategy. Depending on when the Act actually commences, we have 12 months from that date to produce the strategy. So that strategy should be by year end next year. The strategy should be put together and hopefully publication early in New Year 2026. So Thank you so much for listening, and thank you, Vinny, for the invitation to speak. All of the documents I spoke about today are available online. If you're looking for, obviously, I welcome questions later on, but if you're looking for further information, you can feel free to email NOCS, National Office of Community Safety, at justice.ie. And thanks again for listening.
Thank you very much, Grania, and really appreciate again your willingness to participate at very short notice. I'm really interested in your views on the opportunity for structures like the community safety partnerships at a local level, Healthy Ireland programs like Sláintecare, Healthy Communities, and the Healthy Cities and Counties programme, SICAP, and then all the relevant stakeholders within the local economic community plans to shift more towards a sustained, integrated, preventative action. And so we might talk about that later, but really appreciate your input. Thank you very much. So I'd like to continue with I'm going to call it an outsider perspective, but he's anything but an outsider, to look at approaches from Scotland. So I'm delighted that Diarmuid Lawler, a Wexford native who works with the Scottish Futures Trust, has agreed to be with us. Diarmuid is by no means a stranger to Healthy Ireland local government. This is his third time being put in front of an audience that has Healthy Ireland local government involved. And I'm particularly interested in his input with regard to community and the importance of community and their role within the conversation that we're having. And you might give us a short insight into Mind the Crack to explain that as well, Diarmuid, and your view on current thinking with regard to preventative investment by Scottish authorities. So, Diarmuid, thanks for joining us, and we'd love to hear your presentation, so you can begin whenever you're ready.
No problem. Thanks, Vinny, and thanks all. It's hopefully that comes up, Vinny, does it? I was having some trouble with technology earlier, so if you could just let us know.
Diarmuid, that's perfect. Thank you.
Okay, brilliant. Thanks a million. So delighted to be here, and thanks so much. A really powerful and passionate presentation this morning, and thanks, Aoibhinn, in particular, for that huge insight and passion that you deliver. So I'm Diarmuid, I'm from the Ross, I work in Scotland, and I want to offer just three things. The first thing is a community experience of prevention and intervention from Edinburgh. Secondly, it's then so what? And how do we measure and get behind that? And then thirdly, how do we keep going with the investment bit? So community, measurement, investment. A number of years ago, the third sector in Edinburgh looked at the experience of prevention and early intervention from the point of view of community and people who receive services. And there was an engagement of 1,001 voices across the city just to look at what does it feel like? What actually happens? Because if it's a family, it's an integrated bit, it picks up on not one issue like community justice, but loads. And in the testimonials, one person said that prevention is about relationships, and it's the opposite of isolation. It's the opposite of isolation. It was a particular young person who had a drug death in the family and said that isolation comes with relatives dying. So for them, prevention is about relationships. Relationship is about reducing isolation. Reducing isolation is a community issue. It's a service issue. It's a hierarchy issue. A doctor within it then said that relationships are prevention 101, so that the core bit isn't necessarily service integration, though that is important. The core bit is building the foundations, the consistent investment for strong relationships. Relationships are prevention 101. And then building on Professor Austin's, Dr. Austin, is there's some really important stuff going on in Scotland around New Local, around relationships that serve that concept of public service, around serving community. So that was the basis of the Mind the Crack project, which is 1,001 community voices just looking at the experience of prevention. It broke it down into kind of three bits. The first is what works. And what works are where there are community organizations, third sector organizations, GP practices, social prescribing networks, which work like a big family. It's a place that people are able to go in and out without barriers to entry, access what they want, access who they want, when they want it. What works is to have a place to go, and that will vary depending on the person, but it's a consistent place without barriers to entry. Secondly, is that place then is open at the times that it needs to be open, in the way it needs to be open for the families, and people can get together, understand each other, support each other, talk to each other. a really interesting bit around that is that in Scotland, GPs sometimes get involved in arts-based practice and sports-based practice, but becomes really difficult to justify that because you've got clinical priorities and statutory priorities where the evidence is saying that moving across all of these bits really helps. So a supportive network, a supportive host, a supportive environment makes it easier to have those connected practices. Prioritizing specific groups, I guess, building on Avian's bit, just on specific bits. So within the general, then there's opportunities to be able to target the specific, and then a range of programs to choose from. So instead of somebody having to go onto the internet and go on the phone to find stuff, it's a touch point to be able to open the door to lots of things. So what works at community level are those 5 things: somewhere to go, folk to be with, prioritizing your needs, a way of connecting up practices across partners, and programs to support. Interestingly, then people said, well, what needs to work better? And the more specific and targeted we get, then it raises the problem of how do you know the things you don't need? So on the good days, things are good. On the bad days, you didn't expect, you didn't know it. So one of the things people talked about is to have access to relationships, knowledge, partnerships. So on the days you didn't know you needed, it's there. That's about places in crisis, again, and no barriers to entry. It's about services designing activities so they prioritize outreach so that there's touch points, digital touch points, peripatetic models, teams working in communities, redesign of the way that we have strategic and local service points, practicing earlier contact, making programs just really simply available to all the community networks and all the community partnerships so that they don't have to do the hunting. And finally, community groups and third sector groups have very powerful skills, often cash sensitive, time sensitive, don't have access to specialists. So working in collaboration about the skills of local, then the specialists at a kind of locality level, and then at a wider level means we're able to optimize the skills of who's on the ground, skills of who are in the specialist, and then make it easy for people to be able to kind of cut across those bits. However, the challenge coming back from the ground is that the prevention word is often used as an either or. So either we invest in statutory services or we take money out of statutory services and put it in prevention. So they felt it was a kind of a binary thing, whereas the reality is that we need to intervene now in now stuff. And not intervene in now is that, some interventions might be about preventing an eviction tonight, and at the same time advocating for more houses for tomorrow. So the bit that people kind of really talked about was just not making it a binary discussion. It's about now and now plus, if you like. That then drove a really interesting discussion around what is it we're trying to do. So if life is complicated as it is, and I thought that discussion about refugee experiences and those really powerful statistics that were set out, it is complicated. So we could target individual services and individual preventative things around that. Or the ambition is to create the context for happy, functional communities with kindness in systems that create capacity. And that was the interesting bit. It's around the enabling infrastructure for communities. It's around the empathy in the services and how we kind of respond locally, but then it's investing in building the capacity. And there were 4 things that seemed foundational to make that work. So at local level, if we want to have these more relational models, more joined up models, the 4 things that seem really important are: 1, that everybody in that community feels they have a safe base, whatever that means for them. 2 is that they have their voices heard, not just consultation repetition, but actually somebody listening. 3, that around that there are meaningful relationships for a young person, for the mother of the young person, for the person who doesn't speak. And 4, real choices. And that then drives decisions about how we organize services so that the service goes where the people are, how we build intentional, patient and holistic approaches. It takes about 10 years to shift an outcome. You got to be patient, you got to join it up, to invest and support and protect shared spaces so it's accessible and available. It's amazing how little spaces there are in the times that you really need it, and a priority at the kind of city level. Just to give an example, from a different area, this is Doncaster in England. where they were looking at shifting from a kind of an individual service-based model to a relational model. And there were two interesting things about that as you shift. So building on the Edinburgh kind of experience, when you want to shift to that relational model, they said that the two bits of infrastructure are being really clear on the operational bits, what happens. So it's rooted in the place, it's about the whole families, and it's about the communities connected, so you can see clear principles. But the other bit that's really important is the enabling bits, the enabling environment of the practice, clarity on the outcomes, and really, really good governance, to pick up on Dr. Austin's piece as well. But that then allows us to start drawing, defining, designing route maps and pathways, building on Evine's pith, again, building on that idea of happy functional communities, so that if you're living well, all good, then there's opportunities for family to see you doing okay. Then there's a referral bit. Then there's a way of connecting the practitioners before statutory services need to come in. And when statutory services come in, then there's the touchdown and drop down and reconnection kind of point. A challenge, though, within all of this, and in Edinburgh, there is a mechanism called the Integrated Joint Board, which is a link of local authority and the health board. And the financial pressures of focusing budgets on clinical need means that the method of measurement and the evidence around specific things can actually wipe out a lot of what we've just talked about, because it doesn't fit in certain categories. So a couple of things seem important then is, one is a clarity on what we mean by holistic prevention. Second, it's fairness in the method of measurement, so that an individual community organization has real clarity on what's been measured, real clarity on what they're being challenged on, real clarity on the service support, so we're all in it together. And that the use of that is about us moving together. I think what's challenging is where different parts of the system measure differently, and when the conflict comes, as it will, then we're all at 6s and 7s about what we thought we were doing and where we are going. So building that into Gráinne's bit, just I've talked a little bit about the experience of communities on the ground, then bringing that into measurement. Another part of the measurement on that bit of the near term and the long term bit is the place standard and the place and wellbeing outcomes, which are available publicly in Scotland, and a really good resource, because it talks about if we want to create places and communities and we really want to be intentional around it, then the place and wellbeing outcomes have defined it into 5 clusters of outcomes, under which there are measures and indicators which we can get a shared collaborative discussion, shared services, shared investment. And then the process of that is supported by some collateral that you can see in reports that have been done in different places, which are around understanding needs in a holistic way, looking at how that comes together in the way that assets and services come in places, and then shaping specific decisions. So starting from the experience of community, fairness in the measurement, and then looking at the outcomes and how that shifts services, assets, and decision making in the future. So the final slide is bringing that together. In Scotland, there is an interesting report called Delivering a Future for Scottish Local Authorities. It's looking at 2 things. One is the financial challenges around demand rising at community level, and then the second side is around more co-production with communities. So finance, co-production. And it's starting to look at principles of how we would build a different way of public service with prevention at the heart, which uses evidence, which uses collaborative investment. But a key part of that is bullet point 4, which is around a new third sector government relationship, all driven by the shared ambition. That then kind of allows us to kind of think about 3 things that are important to make it work. One is, if we know there are good things happening on the ground, then we need to protect it in budgets, but also in the supportive policy framework. Secondly, we need to have clarity and parity around methods of measurement. And thirdly, if we know it works, then we need to forecast long term, so we have multi-year spend in a multi-year way with kind of strategic partnerships, and that allows us to build all those outcomes that we're looking at the ground. The diagram here then just builds on some of the things that we know are already happening in areas, and the key bit on the protection, measurement, and reshape is amplification. So it's not starting from blank, it's about amplification in areas, local areas that makes a difference, communities around their needs, and kindness in systems. So just to bring it back, the bit I think that's really helpful is checking in with the experience of communities, challenging how we're measuring the outcome of what's already working, and then investing in what works to do more for more with what we have. Thank you.
Thank you very much, Diarmuid. I think we probably could have dedicated a whole webinar to your slides if you were to spend a bit more time on it, and even to get what's inside your head. So thank you very much for your contribution. And I think that means we're at the end of the presentations from the contributors. So we now invite them back to discuss and answer some of your questions raised under Q&A. But if I could maybe ask, and it's a very general question to everyone, having heard what you've heard, just even to respond, and even to Austin O'Carroll's remarks as well. So if we're trying to look at more enabling approaches with regard to prevention or early intervention, what stands out from the inputs for you? And I think even just to put a local government lens on this, within the local government environment, so we're talking about local economic community plan, is there something that really stands out for yourselves that maybe might start a good discussion in relation to just looking at early intervention and prevention in the wider sense? And I might just maybe continue with you, Diarmuid, given that you've heard the different inputs from the Irish context, and you're able to maybe pull in what's happening in Scotland as well, and seeing is there maybe a sense of direction that might be useful for ourselves to explore?
Yeah, so thanks a million, Vinny, really helpful. And I guess across a number of the presentations, what I saw were governance structures with intent. So the intent is to join up, the intent is around the interagency kind of bits, which I think is really powerful. So a lot of the architecture and intention is there. One of the things that is in Scotland, which is interesting, it's messy, it's not defined in law, it's called a place principle, which is a ministerial expectation of collaboration by default. So before you redesign a service, before you build a new building, before you knock down a thing, before you change a thing, how have you actually talked to the other partners, people, and processes in that area to prove that the thing you're about to do maximizes the impact for people? So I think there's something here maybe about the combination between the architecture that you have and then some expectation of collaboration by default as part of the processes moving forward. Not new stuff, just a difficult chat of before you do the thing, how do you know that thing is going to make the biggest difference?
Thank you. Even you're looking to provide an input.
Yeah, I suppose it's a really big question, and I completely agree with Diarmuid. I also think platforms like this, I find one of the issues in Ireland across the board is this division between community and those interventions on the ground versus institutions like hospitals, prisons, who tend to look after the more extremes of cases. And I think until, even for me as a hospital physician to be on this meeting and to show all the different perspectives really enables that joined up thinking and that co-planning and co-design, because without that, if we design community services without the acute or secondary or tertiary input and vice versa, we're setting it up to fail. And again, being able to speak at this and meet with people from various departments and organizations, even virtually, and to know what's happening in other places really enables, for example, our service to expand and to be aware of what's happening on the ground.
Okay, Calma.
I think some of my observations, I think I like the idea of the amplification concept, because again, I suppose that does happen a lot. The new shiny thing comes along and people get distracted by something else or whatever. So I actually do think, because I do have the luxury of having a kind of a helicopter view over lots of different policy domains, and seeing it from the acute end and where that gets the resources, and that the preventative end tends not to. So I think that's really, really important in terms of, I suppose, us not fighting with each other in terms of different ends of the continuum in terms of service provision. I mean, I think from Ireland's perspective, we definitely value the community and voluntary sector. I don't know whether they necessarily always feel that way, but I certainly know from our statistics, I mean, they're crucial in terms of the engagement and that. So I think that's really important in terms of amplifying what's already happening, not coming in with something new. And I think at government department level, really understanding that when you're driving through something, your own policy imperative consider what impact that's having on what's already in existence and what, so kind of scrutinizing it as well from the other side. It's fantastic to get resources for your own program, but you really also, I mean, if we're really working in a whole system, whole of government way, we need to also look at what impact are we having on somebody else who's in that space, or, but I do like that amplification piece. It's great.
Okay. Grania, would you like to comment?
Yeah, and apologies, I keep having to put myself on mute. There's building work has just started behind me, so apologies if there's background noise. I suppose speaking to what Jeremy just mentioned there, the intentionality piece and having kind of an architecture and infrastructure in place to support collaborative working at local, national, across all the levels there. And I was kind of struck by, I think, Colma, it was yourself that was saying about practicing the interagency work. So it's day to day, it's an ethos of working together. And when you're practicing that all the time, then when the crisis intervention area happens, then you're ready for it. But I suppose we're trying to get to a point where the crises are headed off because we prevention early on. And I was struck by what Austin O'Carroll was saying there about the whole piece on community pride. He was speaking specifically around, people who are in addiction, or, communities that have intergenerational trauma and so on. And that, I suppose that's really the community safety concept and initiative is really trying to get back to basics to some extent, and to kind of support communities themselves in terms of their own safety, as well as bringing all of the agencies together to work together. Sorry, I'm just looking through my notes here. That strength of working together, the power of working together. And again, what Dermot, you just said there about the relationship piece, that it's all relational. And ultimately, all of the work that we're doing is, whether you have a policy behind it, whether you have national structures behind it, it's all relational as well. And being able to come together and to come up with good approaches to problem solving and issues, or also good approaches to prevention, and that requires a relational. And that's, I suppose, in terms of the community safety project, for want of a better word, that at local level of the local community safety partnerships, but we also have our steering group. So what you were speaking there, Colma, about being conscious of the impact of an intervention in a specific area and how that impacts other areas, bringing all of the steering group for the National Community Safety, the National Community Safety Steering Group will bring together HSE, TUSLA and Garda Síochána, but also government departments, whether that's the Department of Education, whether it's the Department of Health, whether, and come together in terms of reviewing the responses and initiatives. And I suppose just to say, in terms of that intentionality, there is actually a section in the Police and Community Safety Act which mandates public sector bodies to actually have due regard to harm prevention. So there's a whole piece there. We'll work together in a very positive way, but there's a piece there that sometimes you need the mandate to ensure that people actually do get behind the wheel when it comes to that sustained, integrated, preventative approach. Hope that's...
Thank you very much. Dermot, you wanted to come back in, did you?
Yeah. Just on the community safety, I was just saying to Grania a bit earlier that Police Scotland have invested a lot around different models of policing. So traditionally, the policeman will be in the police building and he'd race around the car solving things. But the model now is more about policing in community and policing in crisis. So it's very much about being where the people are. But they've learned things around that, actually. So one of the things they've learned is that sometimes the police are the best problem finders, but in a relational context, they're not always the best problem solvers, partly because of the perception of the badge and all this, that, and the other, but also partly because of the constraints of the service and what they can offer. So I think seeing it in relation, it might be about what role is it that you take and what role do you have to pass on to the next person, so that the person experiencing support gets joined up support, but you're not locked in to try and solve and all. So that's important. But a second bit is important around that is that individual services are measured individually. But we're talking about all the things wrapping around an individual or a family, which is more complicated. And this is where initiativitis kind of comes in, because you can come in and you can measure your initiative, and I've done it, but it's actually made no difference. So the measurement bit is important because it creates part of that enabling environment for people to be able to do it. Without that, at the end of your year, you're kind of going, so what did you do, Vinny, all year? All the resource we gave. And, I think there is something on that. Problem finder is not necessarily the problem solver. Part of it is about being able to hand over the role. But to do that, you need to have a holistic method of measurement. Otherwise, services and structures will force you down the outputs bit. And I think that's important. So I don't know if that helps me, but it's just an insight that came up from Gráinne's piece.
No, and I think it was Dr. O'Carroll also mentioned it, and asking us to be cynical maybe in relation to KPIs. And it's certainly, I think, something that you are right. There's a plethora of initiatives, and it's having to take that step back and at a local level, I think, in particular, to be able to see where you can have the collaboration, where you can come along and make sure that you're wrapping services around the individual within a local context. And that's why I think it's important that local government is really, really placed in the centre here, because they have so much responsibility for the determinants of health. And it doesn't always come to the fore because there's a public health initiative or HSE or there's SIPSI or there's other structures that deal with that in a specific way. Yet there's so much that local government can actually do to assist and enable all those initiatives to be far more impactful and support them in a way that they can. I just wonder, I suppose it's a question maybe for Aoibhinn and Colma, and I know you're on the Child Poverty and Wellbeing Network, and I've met you at meetings by the Department of An Taoiseach, but this is a message or a query that comes from the Department of An Taoiseach as well, and it's which is heartening. A common thread in the presentations was the question of governance and accountability. Any thoughts on how we need to change approaches to governance that allows for more relational working, for collaboration, for kindness?
I
No.
don't mind, Diarmuid, would you want to go first, or myself? I don't mind.
You go ahead.
Calma, or it doesn't matter. Yeah, Diarmuid, off you go.
No, you go, Colma, you go ahead. I'll follow in. I'll say I don't know.
I suppose I'll be quick, because we would have very clear governance structures within the hospital and within the HSE, but again, they're institute specific. And I'm not operational, I'm very much medical, but I do think that kind of cross-sectoral, be it agreements or regular meetings to discuss your local area, because I find a lot of institutions have very robust systems of governance, but then when you're trying to operate without your own specific circle, things can become more challenging, would be my personal experience of it.
Okay, thank you.
Yeah, so I mean, again, I do think it's different looking at an interagency infrastructure or collaborative practice and the governance of that and what it achieves. I think we have to start with the outcomes, and we have to start with owning the outcomes together. So the outcomes of your population, and then obviously being able to have visibility of disaggregating that, whether that's into specific populations, target groups, etc., or whether it's into specific geographic areas. So that's the tricky piece, I think, for Ireland in terms of how we collect our data, how we display our data, etc. And I know there's lots of really, really good efforts happening under the auspices of both Department of Children and Department of Taoiseach around kind of consolidating that. But I do think that if we're working in a locality, in a county together, you know, we should be looking at the same data and we should be sharing it across our agencies, but we often don't have the investment put into our agencies discreetly or individually to actually do that. Also, I suppose there's an obsession here, I know, around different people's, the structures and the boundaries, etc. So that's tricky, but I think we have to overcome that by just understanding that it's the population in the middle. It's not the local authority, it's not the HSE, it's not TUSLA in the middle. It's actually the population. In this case, for me, it's children and young people, but it could be families. And I think that's mutual accountability for the outcomes of our populations is the key to, if you like, our governance piece. And I suppose I don't think we can graft on a one organisation governance structure to that. I think it's around having that kind of transparency that comes with everybody having a common diagnosis or understanding what's happening in terms of the outcomes and then acting together. We've been through the attribution and all that over years and years and all of those debates. We have to know what we want to achieve, which is better outcomes. And we have to be able to see that we are achieving that as a collective.
And that gives me maybe a nice segue into Diarmuid, maybe just to give us a quick outline on the public services outcomes that you're looking at in Scotland and just even with our conversation today, let's say all the work that's done from, I think it's maybe 20 years ago now, or 15 years ago from the Christie Commission, but the idea of having a common set of outcomes that could be relevant to Grania's work, Evie's work, Colma's work, our work, anyone's work that's looking at trying to improve at the local level.
Yeah, and so about 2011, Campbell Christie led a reform of public services. So he was saying, we're spending loads and people are still poor, and we're spending loads more and it's still not working. So what's not working? So he was quite a modestly provocative man. And he led the discussion around 4 pillars of reform. Prevention was one of them, partnership was another one in place, kind of building it through and saying, okay, so these are the things that we're going to do. So some structures came out of that, like the integrated joint boards, which is to bring local authority and health together around certain things. But a key part of it was the national performance framework, which set overarching outcomes for the country with well-being at the centre. So regardless of your service, you have to evidence how it helps well-being, and then you have to demonstrate that the service kind of comes together. So as an overarching national tool, really helpful, but it's when it comes to the ground, when it comes to the Ross, it's like, what does that actually mean in the Ross? So I think supplementing that have been 3 things that are probably useful to think about. One is there's a really powerful piece of leadership work called Spaces for Listening. And that's all it is. It's like literally people from different services come to listen to each other as humans and as services, and to learn the discipline of making time to hear the other. And it's a 1-hour weekly session driven by a woman called Bridget Russell, who had worked on system change in the NHS. It's called Spaces for Listening. And the provocation is exactly that. It's not about coming in with the answer. It's work out how to listen, because in the listening, it's the empathy and the answer. So framework, bringing this all together, Spaces for Listening. I think the second bit is the accountability principle. So that there is the place principle and national outcomes, but it's saying that there is shared accountability to need as opposed to service structure. And I think that's where, going back to Dr. Austin's bit, it's about inviting challenge around that shared accountability bit. If we are accountable about need, then your annual report will demonstrate how you did it, won't it? And that the choice of collaborative partnerships will demonstrate how you did it, won't it? So there's something around the visibility of accountability around that. But the third one I think is interesting is the one of the problems that will come off is data. We can't share the data, and we've got FOI and millions of acronyms stuff. But this is where local government comes into its own. So there's 2 or 3 people could meet for a chat about the family in Bunclody or what's happening in Campile or whatever. No data gets hurt, but actually it allows us to go. And inside that is a conditionality principle. It's almost a conditionality to chat before you intervene kind of bit. So we don't need new systems per se. We need that. So the overarching outcomes, very powerful. Spaces for Listening, have a look. The accountability and visibility of that in all of the collateral shows that kind of bit is the common intent. But it's the conditionality to chat, I think actually is quite an interesting bit. And if in every work plan or a letter of grant from government to different departments that said, so here's money to do good stuff, but there's a condition in it that you can't do the good stuff until you prove that you've talked to other people in that local area first. Conditionality to chat. So there you go. Space for listening, accountability, and conditionality for chat.
I love it, and it actually gives kind of it's a kind of a template of what we're looking at within some of the Healthy Ireland local government activity. That if you can show evidence of using something like the Play Standard tool or an Irish version of it, where there's significant evidence of engaging and listening to communities and the local agencies, it should influence resource allocation flow for the right reasons. And you're doing exactly that: intervention, early intervention and prevention. So thanks, Dermot. So Grania, a question, I suppose, there's a question after coming in the chat in relation to ensuring representation from from more marginalised groups, and how do you ensure that they get a place at the table in relation to being heard in relation to the local community safety partnerships? But particularly a question then in relation to just having heard and witnessed what you've seen today, what key opportunity area do you see that relates to your work as Director of the Community Safety, the National Community Safety Office?
So I suppose when you're talking about there about the voice of the people who are maybe more distanced from decision making in our communities, and often are the people who are most impacted by community safety issues. Actually, and I know Avian was speaking there earlier about people from new communities who are in IPAS accommodation, and they're afraid to leave their homes and so on. So we recognise that there is a challenge in terms of engaging the people who maybe have had a negative experience of authoritarian structures and so on. So in terms of our guidance and support to the local community safety partnerships, we are actually prefacing that they need to get under the bonnet of who people are impacted by community safety in their area, in their communities, and look at maybe more innovative ways of engagement, because we're very conscious, if you're talking about like a partnership structure with 30 people at the partnership, there is, it's a hard, there has to be kind of quite a strict structure in terms of hearing voices. So the role of the coordinator, the role of the chair, and other ways of engaging those voices, whether that's having, struck by what Diarmuid was saying earlier about going to where people are, going into spaces that people are in. The North Inner City Local Community Safety Partnership has done some very powerful work with people from Roma community, for example. And, there might be learning that we can share with other local community safety partnerships and local authorities there as well. Working collaboratively with colleagues within the local authority structure, whether that's the local area integration team, for example, maybe working in partnership with them. I suppose from the national office's perspective, we're very early stage development, but we're looking and trying to learn from everybody and trying to incorporate and support local community safety partnerships on the ground in terms of ensuring that those voices are heard, that their experience in their communities is heard, and that is factored in terms of interventions and responses to on the ground, whether that's inclusion of particular actions in the local community safety plans, whether it's identifying particular areas that need to be worked with particularly. So when you look at the area-based approach, within the legislation, there is provision for local community safety partnerships to set up local area-based community safety fora. So maybe kind of at a more granular level, and maybe bringing people from those communities in together with public service bodies to look at what's happening in their community at a very local level and make responses for their community at a local level. I'm not sure. And again, we're talking about Healthy Ireland and Sláintecare and other kind of interventions that are being delivered within the local authority structure, working together, because ultimately a lot of our aims and goals are very similar. I spoke at the very beginning there about, many of the I suppose the underpinning the reasons for crime and criminality and so on are actually similar to the social determinants of health. There's lots of different factors in there. But similarly, also speaking a bit of what Diarmuid was saying there about the police in Scotland and that kind of, those kind of two-pronged attack in terms of policing in community and policing in conflict. On Garda Síochána are finding that a huge amount of their time is spent on things and issues relating to things like mental health and, those kind of not actually criminal activity, so there is that whole thing about with the joined up thinking will support the role of the guards, but obviously again what Diarmuid was saying there, when the guards are better interconnected into services, they have the opportunity to be able to, whether it's to connect the individual or family, or to be able to make the other services aware of issues that are emerging in specific areas that they can maybe then address collectively. And I suppose I might be going off point here a little bit, but now Coleman was talking earlier on about the better use of the resources that are already out there. That's another thing, is about reshifting the resources to the needs of the community and to what's actually being experienced on the ground, and working collectively as well, and maybe pooling resources as well to respond to issues that are emerging in communities. I hope that answers, Vinny. I think I might have gone off into another direction there, but.
And Diarmuid, you just wanted to have one quick comment on that?
Yeah, so really powerful, Gráinne, and very helpful. I suppose it's an invitation to ambush, if you like. So if community safety are setting up really good area-based approaches and that's getting stuff started, then other services can kind of ride in on that horse, as opposed to setting up a different version of an area-based approach kind of thing. So if we've got the structures, got the intent, use those structures to move it on, if you like, rather than starting from fresh.
Yeah, I'd agree. And I think something like what I know there's a good number of examples within the Healthy Ireland local government activity with the city and counties where they operate on a municipal district level, Grania, so it gives an opportunity maybe to look at that as an option. Evie, there's a bit of chat there saying, can you print out your presentations and give it to everyone that's canvassing when they hit the front
course.
door?
Yeah. Oh, and it's funny, but I noticed a lot in the chat about people looking to help and support our service. And I honestly, I've lots of high level things that I could do, but at the moment, funding is our biggest priority.
Yeah.
Without
And I
the
was
security, we'll lose it. So talk to anyone, advocate within any departments, the Lynn Clinic and CHI Temple Street.
okay, and we'll certainly try and see, can we talk to people that might be able to. I think the people need to know more about your approach, and that was the obvious message in the Q&A. But I suppose you're gonna answer it already. The most significant challenge you face in your work is funding. But from an early intervention perspective, is there something that local government can be doing? And I think part of the rationale for these is like we are involved in the wellbeing space, but it's in the prevention, it's in the determinants of health, it's being better at what we do in relation to housing, being better at what we do in relation to public realm, all those type of things. What would work
Yeah,
for you?
I have a couple of suggestions, some more or less feasible than others. I'm working with public health at the moment at simple interventions like multivitamins being given out to all children in homeless and in IPAS accommodation, given the number, like something very simple like that. And again, local government, these are things that do not need hospital level care or input. They are basic public and population health. I think because of the nature of our systems, the housing system is very county council, city council dependent. And while I totally appreciate the need for GDPR, you know, a lot of hospital appointments go out by letters. And if a family is moved, then then they're a did not attend, and given 2-year wait list for general peds, they're discharged. And often these children, as I said, are referred with one thing and have a myriad of problems. So I think engagement and this does not just go for children, but adults, we are looking at a more transient and heterogeneous population that even educating other. I've learned a lot about the homeless system, about the IPAS system by virtue of the nature of our work, but I think webinars like this, education platforms for hospital healthcare and other health and social care professionals to understand the systems that we're dependent on would be really, really valid and important.
Thanks very much, Evie. Colma, I'm going to leave the final question for yourself. So it's, I suppose, in relation to your input where you mentioned what a fully functioning city or county, from your perspective with regards to SIPSI, it should be for all of us. But what areas of support, and again, this is local government questions. So what areas specifically of support do you see coming from local government that you think is really important, that you'd love to say, I'd love if local authorities were able to support us by doing X, Y, and Z?
Yeah, no, thanks, Vinny. Yeah, I mean, I think it's seeing children, obviously, and I mean, it's 25% of our population, and 30% if you go up to 24. So it's a considerable, sizable population cohort. So I demonstrate that you see children. Design communities. I mean, it's massive in terms of community design, what local authorities have influence over. And I suppose that's really it, being put children into your frame of reference in terms of planning cycles, etc., and not necessarily as an add-on. People were talking earlier about, you know, how do you get represent, you know, a safety partnership, how does it get, you know, the right people in? I mean, we're a collaborative, so everybody needs to practice listening to the children and young people and to the families, etc. So that for me is, you know, really make a bold statement of recognizing that population from our perspective, and then designing in playgrounds, designing in safe places, designing in youth provision, designing in early years provision, etc. And I suppose it does it a little bit, but I'm not sure we do it consistently. So it's about having that whole system look at the community. What do we have in there? What are we protecting? Dermot said earlier in terms of that's already there, and what are we building up and strengthening? So that would be my ask.
And I think it actually fits beautifully into some of the slides that Dermot had. I think there's opportunity here to have further conversations with the likes of yourselves that are here present on the panel, but a whole load of other people that are operating in this space to look at, is there any learning that we can have that would actually maybe have us doing that early intervention? And I do love the term of mitigating the escalation that Evie used. We can do a lot of work to actually prevent things from getting worse as in do it in the now, like Diarmuid identified, as well as having a longer term preventative focus. And that requires a lot of work because budgeting doesn't really get looked at in an important way from a preventative perspective, because the acute demands always override the preventative focus. I think we're nearing the end of the webinar. I'd sincerely like to thank our contributors and panelists. Dr. Austin O'Carroll, who's over in Italy enjoying himself, really appreciate his input. I would repeat again that there is another version of his input, which is 22 minutes. I think people will be interested in it. He looks at asking people to be cynical of neoliberalism and to be bold. And I think that's important because positive disruption doesn't happen unless people are bold. Dr. Evan Walsh, Grania Burrell, and Diarmuid Lawler, and Colin Lugh, really, and thank you for your inputs this morning. I do know that this is a diverse and wide-ranging area that we tackled, but I hope it's provided some thought for stakeholders within this space, but particularly within local government, to explore some identified opportunity through early intervention and prevention. I'm delighted that we were provided with different insights today, and a challenge. And that challenge and make us appreciate the complexity of some of this work. So I thoroughly enjoyed it. I hope those in attendance have too. And I'd like to acknowledge IMS Connect, who managed the operations today. Dave Mitchell, my colleague in the National Office, for his support. Finally, I'd like to thank you for attending. We had over 180 registered or in attendance at the event today. So thank you for your interest. And I hope today has been a learning experience for you all. In that regard, can I ask that you complete the feedback form that will pop up on your screens in a few moments? Your feedback will help shape the type of future events that we might develop that could be relevant to you working in the wellbeing space. Can I finally wish you the very best for the remaining weeks of 2024? I'm not going to mention the festivity period. So finally, Gurab Mila Mahagav Agus Slán Liv Galir.